بسم الله الرحمن الرحيم. الحقيقة بنشكر الأورجنايزنج كوميتي وبروفيسور محمد عبد الغني وبروفيسور محمد محسن إبراهيم for this important meeting. And now we will have the Menarini Symposium, and it's my pleasure to introduce our Professor Muhammad Abdel Ghany. هيكلمنا على innovation in ischemia management.
Good afternoon. This is the Menarini Symposium. We are going to talk about innovation in ischemia management. Coronary artery disease is ranked as number 15 worldwide. Mortality is around 30% annually. 2019 European guidelines mentioned 3 pillars for the treatment of stable angina with new terminology, chronic coronary syndrome: lifestyle modification, medical therapy, and revascularization. In this lecture, we are concerned with medical therapy. When you are confronted with a patient with chest pain, likely ischemic, you can start with whatever you want. You can go for non-invasive testing if you are looking for viability, if your patient has likelihood of ischemic heart disease, if revascularization is likely. But if he has low clinical likelihood of ischemic heart disease, no history of coronary artery disease, and patient characteristics, image-wise is good, you can go for multi-slice CT coronary angio. And guidelines allow you to go directly to invasive coronary angio if patient has severe symptoms, left ventricular dysfunction, ECG changes, highly positive exercise test. So whatever you like, just choose your patient and the proper modality of treatment. After diagnostic coronary angio, after knowing the anatomy, now you can go for revascularization if you have severe obstruction or medical therapy. PCI is not the ultimate solution. Remember that 20 to 30% of your patients after PCI were symptomatized from angina after 1 year. Angina, PCI, 1 year, 20 to 30%. In the famous ischemia trial, in patients with a stable coronary artery disease showing moderate to severe ischemia, initial interventional treatment did not prevent recurrent events more than initial conservative treatment. So there is a rule for medical treatment. In the ORBIT trial, patients medically treated angina with severe coronary stenosis, PCI did not increase exercise time by more than the effect of placebo procedure. Still, medical treatment is there. So, European guidelines 2019 simply stated that you have first-line treatment. You can start your treatment in patients with chronic coronary syndrome with beta blockers, calcium channel blockers, or combination. Gold standard, very simple. If your patient is not controlled or there is a contraindication, you can go to the second line, Second lines are important as first line. You can start second line with long-acting nitrates. You can go for ranolazine, ivabradine, trimetazidine, or combinations of first line, second line. Of course, the guidelines was clear. Indications of ranolazine indicated as second line, class 2, level of evidence A. In subjects with low heart rate and low blood pressure, ranolazine is first line. In cases of contraindication of beta blockers, you can start with ranolazine. So ranolazine always there. You have to select your medical prescription according to the hemodynamics of your patients. When my blood pressure is low, ranolazine will come to show itself as a first line, whatever my heart rate is. However, when the heart rate is above 60 and systolic blood pressure above 120, again, first line is beta blocker, non-dihydro calcium channel blocker, second line ranolazine. The British guidelines, again, was clear for people on beta blocker or calcium channel blocker monotherapy whose symptoms are not controlled or beta blockers are contraindicated. Please consider the following: long-acting nitrates, ivabradine, or nicorandil, or ranolazine. The American guidelines actually regarding second line of treatment, they chose only one molecule, ranolazine. If you have contraindication to beta blockers or beta blockers are not effective, your alternative is one molecule, ranolazine, according to the American guidelines. Here you can see that European guidelines mentioned ivabradine, ranolazine, nicorandil, trimetazidine, American only ranolazine. The FDA approval for ranolazine since 2006 was clear. It is indicated in the treatment of chronic angina. It may be used with beta blockers, nitrates, calcium channel blockers, antiplatelet, lipid-lowering therapy, and ACE inhibitors. So let us focus for a few minutes on ranolazine. Ranolazine mechanism of action is unique. We all know the fast sodium currents. From our physiology, we know that we have what is called fast sodium current. But few of us know that we have another sodium currents called slow or late sodium currents. Usually it comes late, and it is not important in normal persons. However, in ischemic persons, it is highly active, bringing more sodium to the cell. Sodium takes calcium with it through sodium-calcium exchange. Now the cell is loaded with sodium and calcium. Calcium-loaded cell has electrical instability, liable to arrhythmia. Cell has impaired contractility due to diastolic tension, have reduced oxygen supply, increased demand due to increased ATP consumption and the reduction in its formation. Now, look what ranolazine can do. It blocks the late activated, slow, late sodium currents. Thus, it reduces sodium and the calcium tension in the ischemic cell. It has antiarrhythmic activity. It is called 1D antiarrhythmic. We know classification, and we know 1, 2, 3, 4 antiarrhythmics, 1 ABC. Now we have 1D antiarrhythmic drug, ranolazine. Ranolazine can improve through this mechanism diastolic tension, improving contractility, and increasing oxygen supply. We have a plethora of clinical trials. How to test a patient with chronic coronary syndrome? Go for exercise test, see the duration of exercise test, see the time to produce angina, see time to ST depression. This is how the investigators test an anti-anginal medication. In the MARISA trial, they tested ranolazine as a monotherapy. The yellow bar is a placebo, then different doses were applied, 500, 1,000, and 1,500. Look, as we increasing the dose, we have better exercise duration, longer time to angina, longer time to 1 millimeter ST depression. This was true whether your patient at trough time, at 12 hours after administration, or at peak time, 4 hours after administration. CARISA trial is testing the combination of ranolazine with either amlodipine, atenolol, diltiazem. Again, we can see that the exercise test parameters are improving after administration of ranolazine. Look to the angina frequency parameters. Look to the consumption of nitrates, nitroglycerin, less consumption of nitroglycerin, and mean number of anginal attacks are reducing, giving the 2 doses after the yellow placebo bar. ERIC trial testing ranolazine after maximum recommended dose of amlodipine. Again, angina frequency parameters reduced clearly with a statistical significant value after giving ranolazine. And it had no significant difference in hemodynamics. Ranolazine is a hemodynamically inactive drug. Again, ranolazine, hemodynamically inactive. No change in blood pressure, no change in heart rate, no change on left ventricular function, no change in hemodynamics. TERESA trial was conducted on diabetic patients. Whatever the level of glycosylated hemoglobin, you have more benefit with ranolazine. Look to your right side graph. Menarini-Mohamed 36 is a mega trial. 3,500 patients, half of them have chronic angina. Look to the cardiovascular primary endpoint outcome. We have no effect on cardiovascular death. We have no effect on cardiovascular myocardial infarction. However, combined endpoints using recurrent ischemia was better using this molecule. Menarini-Mohamed 36 tested the prolongation of QT interval because we know that this molecule can prolong the QT. The upper limit of QT is 450 milliseconds, male, 460 in female. Yes, this molecule can prolong QT by 5 milliseconds. Nothing. However, in patients with heart failure or ischemia, it has no effect on QT interval. And in the Merlin-Timmy was no effect in QT versus placebo. This is an interesting meta-analysis. They tested the effect of different combinations. Look how marvelous when you add calcium channel blocker to beta blocker, when you add long-acting nitrates to beta blocker or calcium channel blocker. The same wonderful results was clear in this meta-analysis when ranolazine was added to beta blocker or calcium channel blocker regarding exercise testing duration or clinical outcome. So the idea of combination was very clear. This was not true when trimetazidine, for example, was added to beta blocker or calcium channel blocker or ivabradine to beta blocker. Ladies and gentlemen, this is my take-home message. In chronic coronary syndrome, conventional therapy with beta blocker, calcium channel blockers, and nitrates remain the cornerstone of anti-anginal therapy. Very clear. The use of newer anti-anginal therapy may increase the possibility of more effective anginal symptomatic control. In our country, we need medical treatment. PCI or surgery are not the ultimate solution in some patients. Ranolazine does not affect the heart rate, blood pressure, or bronchial activity. Ranolazine is well tolerated with a proven safety profile, and its minimal QT interval prolongation is without clinical sequelae. Thank you.
شكرا دكتور محمد for this very elegant presentation and طبعا السهل الممتنع كما تعودنا. طبعا الرانولازين واحد من الeffective drugs وكانوا widely used in the States were recently introduced in Egypt. بالنسبة للسؤال هو supplied في 3 doses. أولا يعني why 3 doses? And what would you recommend for patients uncontrolled on the traditional management?
Thank you for the question. Yes, in Egypt, we have 3 doses, 375, 500, and 1,000. You should start with 375 for 1 month. No side effects. Patient is controlled or not. You have to upload the concentration to 500 twice per day. And at this stage, look to the symptoms. If not controlled, you can increase more after 1 month to the full dose, 1,500 twice daily. This is not just dose used in Europe or in some studies. There, they have 500, 1,000, and 1,500. In Egypt, I'm not sure why the company chose to start with these doses in our Egyptian market.
شكرا دكتور محمد. سؤال برضك ثاني. When should we not use ranolazine?
Smart question. In patients who has prolonged QT interval, in patients who are taking medications that may prolong the QT, like of course class 1, class 3 antiarrhythmic drugs. In patients with GFR less than 30, in patients with moderate or severe hepatic disease, in patients receiving anti-cytochrome B130, because this is the way the hepatic pathway is metabolizing ranolazine. In patients consuming metformin in a large dose, just monitor the blood sugar.
It's a metabolically acting medication. Can we combine more than metabolically acting agent to treat the patient?
Thank you. Actually, we don't have data. It's logic with different combinations are allowed, but the metabolically active drugs against ischemia, it's logic to combine, but we don't have data to suggest or encourage.
شكرا دكتور محمد، شكرا جدا.